So we'll have a first case discussion. Sorry, it's not Dr. Revati, it is Dr. Mohitha from Comtrust. She's presenting a case, which is a common scenario that we all face in daily.
Good afternoon, everyone. Thank you, KSOS and my guru, Dr. Bindu Madam, for giving me this opportunity to present over here. So I would like to begin with a case which is common but challenging. This is a story of a young girl with myopia of minus 1.75 and minus 0.25 with a strong family history of glaucoma. On examination, she was having a thicker cornea and the IOP was measured using applanation tonometry. It was 17 millimeters of mercury in right eye and 16 millimeters of mercury in left eye, and there was no diurnal variation during office hours. This is a fundus picture which shows a large disc with a cup disc ratio of 0.7 both eyes, and NRR was pink and healthy, and in the right eye there was a bearing of vessels in superiorly and no RNFL defect. This is the HFA printout, both 24-2 and 10-2 are within normal, but her OCT shows suspicious changes. But the progression analysis of OCT shows stable MRW over time, and the big question is this an early glaucoma, an artifact, myopic thinning, or something genetic? This is an important scenario because it is extremely common in glaucoma practice. OCT detects structural damage earlier than functional loss. If we over-interpret OCT, we may overdiagnose glaucoma, and if we ignore OCT changes, we may miss early disease. So glaucoma diagnosis always requires two pillars: structural assessment by OCT and functional assessment HFA. Early glaucoma often shows up first as structural loss on OCT long before the visual field shows any defect. This is supported by multiple studies. Here I highlight one landmark study. This study demonstrates that RNFL and GCC thinning at baseline strongly predict future visual field loss in glaucoma suspect and pre-perimetric glaucoma. So before we label a patient as glaucoma, our first duty is to rule out OCT errors. OCT can give false abnormal results due to three groups of factors: machine-dependent factor, operator-dependent factor, as well as patient-dependent factor. So when interpreting OCT scans, one of the most important parameter to check first is the signal quality. For the Cirrus HD OCT system, image reliability is assessed using the signal strength value. If the signal strength is below 6, the scan quality is considered poor and the test should ideally be repeated. On the other hand, in the Spectralis OCT, it uses a different metric. It uses quality score, and a Q score of less than 20 requires repetition of the test. This is OCT of a different patient, in the right eye showing motion artifact and the left eye showing blink artifact. And once we confirm that the scan quality is adequate, the next thing to look is for segmentation error. Segmentation error occurs when the software is unable to correctly distinguish between the retinal layers. In such cases, the RNFL or the other retinal layer being assessed is measured as thicker or more commonly thinner than actually it is. In the first scan, there is supranasal and nasal RNFL thinning, and the B scan highlighted by the red arrow where the RNFL segmentation line is misdrawn. This creates an artificial thinning and falsely pushes the RNFL value into the outside normal limit zone. On the other hand, the repeat scan shows a clean B scan with a proper segmentation, and the RNFL thickness returns to within normal. So after we exclude segmentation error, the next major cause of misleading OCT is the high myopia. High myopia, the eye is elongated, which it stretches the retina. As a result, the RNFL and macular layers are naturally thinner for those patients. Because the OCT compares them to non-myopic reference base, it may incorrectly label them as thin and abnormal, what we called it as red disease. And in contrast, macular degeneration produces true retinal thinning and sometimes mimic glaucomatous damage. Now that we have seen how careful analysis are crucial for diagnosis, let's focus on one of the key risks of glaucoma, something which is not mentioned where there are the multiple large population studies as mentioned here found that family history is an important risk factor for developing glaucoma. So unlike in children, the inheritance pattern in adult is complex because of its polygenic nature of inheritance. Almost 100 genetic variants have been associated with glaucoma, and the penetrance can be variable. That is, not everyone who has a risk gene will develop the disease. So, a few words about polygenic risk score. It's a single numerical value that estimates a person's inherited risk of developing a disease based on a combined effect of many small genetic variations across their genome. Unlike rare single gene mutation, which have a larger individual effect, most common glaucoma cases are influenced by hundreds of tiny small genetic differences, each contributing only a small amount of risk. Now coming back to our case, the point which are against the diagnosis of glaucoma are HFA 24-2, 10-2 within normal, CCT on the thicker side, and GCC within normal. And the points which are favoring glaucoma are family history, myopia, and red disease. So my question to the panelist is that how do we move forward in such cases, and does genetic testing have a role in this type of cases?
Glaucoma.
Ma'am, it's a young girl, myopic fundus, and 0.7 cupping in both eyes, and right eye showed a bearing of vessel seen, and the HFA was normal, but OCT showed thinning.
So macula GCC.
Within normal.
So
And the strong family history of glaucoma also.
Where is the thinning in this? OCT show thinning where?
RNFL.
RNFL show that. Okay, this is the scan you have. Very good. Okay, next one, which picture you have?
Progression analysis.
whether
Strong family
List
history of
is there.
glaucoma. Myopic with IUP 1617, disc looking, a large disc, large cup, with an OCT of a red signal. She's asking whether
To treat or not to treat?
not to treat. How do you go about it now? They are very apprehensive because the family, her father underwent TRAP and very high progressive disease. The father.
Do meditation.
no. Yeah, what I feel is right now we just observe, but again polygenic risk score. I mean, we have just started doing one study, but problem is cost. So we still have not found any single gene in Indian family or Indian scenario which will predict that this person will develop glaucoma. So right now I think it's in a very, very nascent stage. For us also the funding was very less, so we have just doing very, very, very few patients. So it becomes a little challenging to do a genetic study and predict whether this person will develop glaucoma or not. A lot of studies are happening actually in GSI. Dr. Monisha from Singapore, she's doing a lot of study on polygenic risk score.
Thank you.
One thing which she said is right, that polygenic risk score, though we haven't done so, it is too early for us to say it's good or bad. We'll have to just observe. The second part what he said is like the funding is very less for them. It's not a true sentence that she's making. So so it is probably we can just observe for time being, though this is not the right way that you see the progression. I've already told Bindu what is to be done. So just for to teach you, if you see that the bottom right, okay, there is a which area it is taken for the progression, the circle. So you have taken from the general. So overall whether there is a progression. So you see the area where you really wanted to focus on. So you wanted to focus on the inferior temporal. So you see the progression in the inferior temporal area, then you will understand whether the patient has any progression or not. So focal areas of interest will really help you to see the progression. Then overall it will just pull up. See that last one, which is much better than the previous ones. So the scans, how it has been done in myopes, it is always little tricky to have a good scans done. So we'll have to see a little bit more carefully in depth how the scans are done, how you see the progression, everything. But as of now, we understand that there is not much of a change. So observe, but nothing wrong in going in for the polygenic risk scoring.
Thank you.
Okay.